Today's topic of discussion is going to be on ankle fractures. So we are going to be discussing upon is the biomechanics, classification, treatment and complication. So the biomechanics is basically the ankle joint is formed by the syndesmosis between the distal tibia and fibula and a mortise between the distal tibia, fibula and the talus. And the mortise joint, the mortise which is formed by the tibia and fibula, and the tenon is formed by the talus which fits into the tibia and fibula. The ankle joint is a uniplanar hinge joint, and but some rotations of the talus happens. It's because it's lying in the mortise. The distal fibula, it's a static buttress for the talus where it bears the 1/6 of the weight, and the distal fibula moves distally, that is around 2.4 mm when moving from non-weight bearing to weight bearing. So which helps in deepening the mortise. So the ankle stabilizers are basically the shape of the talus, which provides to fit inside the mortise, the intraosseous membrane, the anterior and posterior talofibular ligament, calcaneofibular ligament, deltoid ligament, and the ankle joint capsule. Okay, the lateral malleus displacement is more. So you can see on weight bearing, it deepens the mortise to fit the talus into the mortise. So in dorsiflexion, the fibula glides anteriorly and the talus abducts. So in plantar flexion, the fibula glides posteriorly and the talus adducts. So this mechanism on the truncated cone accounts for the stability of the normal ankle joint throughout the range of motion and without any changes in the ankle space. And whenever there is a fractures around the ankle, you basically concentrate on the history is the mechanism of injury, soft tissue related injury which associated with it, the comorbidities the patient has, and any other associated injuries. And on physical examination, you see the skin around the ankle joint, whether it is tense because of the swelling, any nerves injury, vascular injury, and what is the status of the pain and the deformity. And when later following that, which you take an X-ray of the ankle joint, there is a tibio-fibular overlap of around 10 mm, and then tibulo-fibular clear space which has to be less than 5 mm, and the talar tilt which has to be less than 5 degrees. And something called a mortise view, which is taken in the foot, there is 10 to 15 degrees with the internal rotation of the foot, where the fifth metatarsal with respect to the vertical line. So which shows the intraosseous membrane in the mortise view. So in the mortise view, we will see the medial joint space which we can see between the talus and the medial malleoli, and the talocrural angle which is less than 8 degrees or more than 15 degrees, which is formed by the distal part of the tibia and with the line joining both the medial and the lateral malleoli. So this angle, and then the tibular-fibular overlap which has to be more than 1 mm. And there is something called the Shenton's line of the ankle, which is formed by the medial malleoli, the distal tibula, and the medial border of the fibula. Okay. And there is something called the dime sign, that is on the weight bearing ankle, there is a circular area formed by the talus and the fibula. So if the fibula is proximally migrated, the circle is not formed and there is a break in this dime. Okay, in the lateral view, yes, we have to basically focus on the posterior malleolus, the talar subluxation, the distal fibular translation, and associated lateral process of talus, any talus or calcaneal fracture. Other imaging modality we can see is the stress view of the gravity. What happens? This one, with the patient lying supine, you hold the distal end of the leg and push the foot laterally. So if there is a disruption of the intraosseous membrane, so there will be increase in the distance between the tibia and fibula. Then if there is a fracture involving the articulating surface or the posterior malleus, a CT can be held, which shows the fracture pattern and the size of the fragment. And to know any of the ligament injuries, we need MRI to see even the talar dome lesion or the syndesmotic injuries. So this is a stress view taken, which is taken with both the sides to just for the comparison with the holding the distal part of the leg, and inversion and supination stress on the ankle has been taken. And for subluxation in the lateral view, that is the subluxation of the talus, a lateral view of the ankle is taken, and in the anterior shift of the talus has been noted. If it is more than 8 to 10 mm compared to the uninjured angle, that indicates the ligamentous injury. So classification, there is a Lauge-Hansen classification, which basically has the two words, in which the first word it shows the position of the foot at the time of the injury. The second word, force applied to the foot relative to the tibia at the time of injury. And remember, the injury starts on the tight side of the ankle first, and the lateral side is the tight in supination, while the medial side is tight in pronation. So based on this, we will have supination external rotation, supination adduction, pronation external rotation, and pronation and adduction. So supination external rotation, in which the stage 1 what happens is, so the tight side of the ankle is the medial side, where it happens is anterior talofibular ligament is being torn first. Then in stage 2, that if you continue in this direction of the supination and external rotation, fibula fracture happens. And then further, if it continues, the posterior inferior talofibular ligament is injured, or the posterior malleoli is fractured, and stage 4 is deltoid, or the medial malleoli is fractured. So which you can see that classic posterior superior and anterior inferior fibula fracture. It is the line of the fracture line extending from posterior superior to anterior inferior. And medial injury, stability is maintained, but deltoid ligament can be fractured. So that will be management as closed fracture. And if it is unstable, we can see that there is a medial malleoli fracture, okay, and the fibula fracture, that is again from the posterior superior to anterior inferior fibula fracture with medial malleoli fracture with subluxation. So in subluxation, you can see medial joint space is increased, the fibula is displaced laterally, syndesmotic injury is present. So this has to be done as surgical management. So we'll be discussing about the surgical management later. And then there is a third mechanism of injury, the supination adduction, in which stage 1 is the transverse. Supination adduction results in the fibula fracture, which can be transverse. And in stage 2, if you continue the further, the tension side in supination adduction will be lateral. So hence first the fibula will give away, hence transverse fracture in the fibula. Then if you continue in the adduction, that causes a medial malleoli fracture. Okay, so we can see the lateral malleoli or the distal end of the fibula, transverse fracture, and the medial malleoli fracture. Here the classical what can be missed is the impaction. So if the talus gets impacted in the distal end of the tibia, there might be a depressed fracture which can be missed. So here again ankle stability because syndesmotic injury is there, and arterial congruency including the medial impaction has to be corrected. Supination adduction. So this is for the approach for the surgery, which you can anterior medial approach, and if impaction is severe, bone grafting can be done and plating is an option. So we can see the medial side plating. Pronation-external rotation, the fourth mechanism. So here in pronation, so what happens is the medial side is under tension. So the medial side first the injury is going to happen, whether it can be the deltoid ligament which can be injured or the medial malleoli. And then in the stage 2, if then it is continued, the anterior inferior tibiofibular ligament is injured, and then the interosseous membrane which causes syndesmotic injury. Then stage 3, still further external rotation causes the fibula fracture. Here in external rotation, the fibula fracture is higher up, and that is why it's Weber C. We will be discussing about the Weber classification. Then further external rotation will cause posterior inferior talofibular ligament injury or the posterior malleoli fracture. So we can see here the deltoid ligament is injured, then medial joint space is increased, syndesmotic injury, and the fibula fracture, that is Weber type C, that is a spiral fracture. Okay. So highly unstable because of and in this syndesmotic injury is very common, hence it needs to be operated. Okay, so here we can see we have operated, fibula has been fixed. Those two screws between the tibia and fibula are the for the syndesmotic injury, for providing the ankle stability. Then we have the pronation abduction injury. As usual, pronation tension side will be medial, so transverse medial malleoli fracture can be noted, and the posterior inferior talofibular ligament or the posterior malleoli fracture. If you continue more of abduction, so compression bending, fracture of the fibula will happen. Which you can see the medial malleoli fracture, the distal fibula fracture, because it's combination, and hence we fix with plating, and the medial malleoli can be fixed either with the screws or tension band wiring. So one more classification is the Danis-Weber classification. Is based on the location and the appearance of the fibula fracture. So type A is nothing but a fracture which is distal to the syndesmosis or the interosseous membrane, and can be associated with the fracture of the medial malleolus caused by internal rotation and abduction. So equivalent to supination and abduction fracture. Okay, type B is at the level of the syndesmosis, so which can be avulsion of the anterior inferior tibiofibular ligament, or the deltoid ligament can also be associated. Is caused by external rotation equivalent to supination external rotation. Type C is higher up, higher than the syndesmotic level, with disruption of the interosseous membrane, then it will be C2, without it will be C1. AO classification. It's basically the fibula fracture below syndesmosis, then fibula fracture at the level of syndesmosis, and suprasyndesmotic, okay, with complex with the medial malleus or without medial malleus. Okay, now a few points about the posterior malleus. Its basically function is to provide the posterior translation of the talus, prevent the posterior translation of talus, and enhance the syndesmotic stability. And in the weight bearing, increases the surface area of the ankle joint. So fracture pattern can be variable, hence CT is usually required to know the fracture pattern and the size. So that since we need the sizes, because for the indication for fixation, if more than 25% of the joint surface is involved on the lateral view, so hence we need to operate, because it is the weight bearing area of the joint. So which can say 67% of the fracture of the posterior malleus is of the oblique type, and approximately around 20% is the medial, with the medial extension is there, and the third and the small shell type, that is accounts to around 14%. So indications for fixation is, one is posterior translation of talus happens, that is in the stress view, the lateral view. Stress X-ray is taken in the lateral view, external rotation of the talus, articular congruence, that is stress is equal to force by area. So excessive stress, that is post-traumatic arthritis, will develop, okay, because it's a weight bearing area of the joint. So from posterior malleus we come to syndesmotic injury. The function of it is to basically provide stability, resist external rotation, axial and lateral displacement of the talus, and in weight bearing allows for the standard loading. So we have already discussed in the X-ray of the ankle joint. So to indicate the syndesmotic integrity is that tibiofibular overlap, lateral border of the anterior tibial prominence and the medial border of the fibula, the overlap should be less than 10 mm, and the tibiofibular clear space, that is the interosseous clear space, the distance between the lateral border of the posterior tibial malleoli and the medial border of fibula should be more than 5 mm. So if instability is present, you have to operate. Okay. So how do you decide whether the syndesmotic injury is present intra-op? That is something called a hook test or the manual stress test. Intra-op, after the fixation of the fibula, a hook is passed on the fibula and pulled laterally. So if the space between the tibia and fibula is increased, that means it is syndesmotic injury or the unstable ankle joint, which needs to be fixed with a syndesmotic screw. Okay, so that we can see there are various ways of fixation. That is a single screw which can be passed through the syndesmotic with 3 cortices, or a single screw with 4 cortices, or 2 screws with 6 or 8 cortices. So this is a flow chart for you to undergo. It's with basically it is that whenever the ankle joint is unstable, it needs to be fixed. Okay. So various ways of fixation is of medial malleus is via malleolar screw, and a malleolar screw with K wire or a tension band wiring, and fibula with, you can usually fix with a plating or a K wire or a rush pin. These are the various ways of fixing even the lateral malleus. And posterior malleus, as usual, I have told the indications being 25 to 50% of the weight bearing surface is involved by posterior subluxation of talus or the persistent posterior instability. So which we can see can be fixed with screws or plate. Complication mainly associated is perioperative is malreduction, inadequate fixation, intra-articular hardware penetration. Early postoperative will be wound edge necrosis, which is very common in ankle joint fractures, is basically because the skin is very tense and chances of necrosis is very high, which can lead to infection and then compartment syndrome. Late is associated with the articular incongruity that can lead to stiffness, distal tibiofibular synostosis, malunion, non-union, post-traumatic arthritis, and hardware related complications.